The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everybody. Thank you for joining our webinar tonight. I would like to introduce Dr. Evan Matthew. He's the epileptologist with the Northeast Regional Epilepsy Group. He will be presenting treating epilepsy with surgery tonight. There will be no question and answer session tonight. But however, should you have any questions, please you can email it to me directly, or you're going to have an email by the end of the session, and you'll be able to email it to them too, and we will be responding back to all the questions. Again, I want to thank everybody who come into our webinar, and I'll introduce Dr. Evan Matthew to start. Dr. Evan, it's all yours.
So welcome. Tonight we will discuss several things and even going into some of these graphics here. So on the left is reconstruction of an implanted brain, and we'll review what that means. And then on the right is actual intraoperative in the OR picture of where what these grids and strips look like. So objectives for tonight. I just want to give an overview. I know in previous webinars we've reviewed evaluation diagnosis of epilepsy, but just a quick overview of that as well. That's very important and pertains to the surgical workup. Also, just to review different seizure types and what types would be appropriate and what conditions would be appropriate for surgery. And the discussion will mainly be around the cases that aren't responding to medications and the pre-surgical evaluation. And we'd break it down into two phases. Some groups break it down into more, but just to keep things simple, we'll do phase one is a pre-surgical evaluation, and then phase two is what we saw earlier when these electrodes will be placed on the brain itself in order to identify the area of brain that's causing the seizures. And then that would proceed to the epilepsy surgery itself. Or if we're not able to isolate the seizures, there are other implantable devices. So there's a few questions that we all have to ask ourselves as epileptologists and clearly patients. Is number one, is this epilepsy? So there's several conditions that it looks like patients are having an epileptic attack, but in fact it's not necessarily the diagnosis of epilepsy, and we'll get back to that definition. Um, if it is epilepsy, we need to know what type of epilepsy it is, and that is very important as well, because of treatment options. And again, if it is epilepsy, which medications out of the 20 plus medications, which ones are going to be best for that type? And then last of all, what happens if medications fail to control the seizures? And that's where the remainder of the talk will be about possible surgical options if medications do fail. Initially, all epilepsy evaluations begin with a detailed history. And the history, you can make the diagnosis of epilepsy purely by listening to the patients, and they'll give very specific descriptions. And we like to do all these tests, but truly the diagnosis, most of it actually does come from just listening to patients, and it's important for your doctor to listen to and validate exactly what you're telling them. Detailed neurological examination, of course, and all this testing that we do, blood work, and if needed, a drug screen, um, imaging, looking at the structure of the brain tissue, and then EEG, which is the electroencephalogram, which looks at the function of the brain tissue. So the question is this epilepsy? I just want to briefly review three separate cases. The first would be a 48-year-old male and who presents to the emergency department after a first-time convulsion. And the second is a 32-year-old female with uncontrolled convulsions for the past couple of years. And the third, a 20-year-old female with uncontrolled convulsions. So starting out with a 48-year-old male, he had a convulsion, history, really no medical problems, not taking anything. His neurologic examination showed just some left arm weakness. Everything else is completely normal. Blood work was normal, and a CAT scan looking at the structure of the brain showed a large brain tumor. The EEG was done because it was a seizure, and it showed just some slowing, which is the brain's not functioning properly, so that area is a little bit slower than the rest of the brain. And so the diagnosis isn't epilepsy; it's actually a provoked seizure, a seizure that was caused by something else. And so the treatment is actually just to remove the tumor. And this is just a depiction of a very large tumor in the right front part of the brain. This is the front. And the way that we look at images, this is actually the right side, and this is the left. The second case, a 32-year-old female with uncontrolled convulsions. Um, she had some migraines and these spells. She had been tried on 8 different AEDs stands for anti-epileptic drugs. So 8 different seizure medications and still having spells. Normal exam, blood work was fine, an MRI was normal. All the, lab work was normal. A video EEG showed her typical seizures with body thrusting and her arms flailing around. So the diagnosis was actually a psychogenic non-epileptic spells, which is not epilepsy, and it's treated by a psychological evaluation and sometimes psychotherapy. And this is just a depiction from the 1500s, a painting of, they used to call it hysteria. So this last case, a 20-year-old female with uncontrolled convulsions for the past several years. She did have seizures as an infant that were always associated with a fever, high fever. And now her exam was normal, blood work is normal. But the MRI showed some scarring in the brain, and particularly it's this condition called mesial temporal sclerosis. And EEG showed these spikes, we call them epileptiform activity, but the spikes are sharp, indicating irritability, and the diagnosis is, in fact, epilepsy in this case, and the treatment is medications. And this is just an MRI of this left. This is an area of the brain that's very common where seizures would start in the temporal lobe, and this brighter area indicating a scar in that area. So treatment. What do we do? If it is in fact epilepsy, or if it is in fact a seizure, is it a provoked seizure or an unprovoked seizure? Provoked meaning the most common would be an alcohol withdrawal related seizure or other drugs, or a trauma, or even a tumor causing swelling. An unprovoked seizure is just out of the blue, and everything else being normal and nothing else, no other explanation. Other factors, is this a single isolated seizure, or are these events happening over and over? And clearly the testing, if the MRI and the CAT scan are abnormal, or if the EEG is abnormal, that's going to help your doctor understand what type of treatments may be needed. The type of epilepsy, and we'll get to this quickly, there's 2 main groups of seizures. There's a group that starts in a particular focus, or focal epilepsy, and also generalized, where the entire brain is irritated all at the same time and it causes a seizure. So I just want to review the basic definitions. And don't worry, we'll get into the surgery. But right now, just to review basic things. A seizure is when the neurons all come together and synchronize, so they all start to have this surge of electricity in a certain area causing a convulsion or a seizure. Epilepsy, on the other hand, is recurrent seizures. So this excessive excitation or these electrical bursts or electrical storms in the brain, two or more of those which are not provoked. So these are unprovoked seizures. There's no other cause. How common are these seizures? Your chance of having a seizure just in general in the population is almost 10%. So 1 out of every 10 persons may in fact have a seizure in their lifetime, which is pretty high if 1 out of every 10. So, but a third of these are actually seizures that children have or infants have associated with a fever. Epilepsy affects 1% of the population. 1 out of 100 doesn't sound like a lot, but when you multiply that over 350 million people in the U.S., 350,000 cases that's a lot. This is the international classification of seizures. Again, it breaks them down into these partial or focal seizures or generalized seizures. And this has been reviewed in other talks. I don't need to get into too many details, but the type that is most amenable to epilepsy surgery are these partial or focal onset seizures. So, which brings us to epilepsy in general. Once we do have a diagnosis, you're on treatment. 2/3 of patients will be completely controlled on medication. In fact, simply on one, maybe two medications. But there are about 30% of patients with epilepsy that are not controlled by medication, and this leads to their quality of life issues. People, children have a hard time in school or unable to go to school. Working is an issue, and driving is a major issue, especially in the East here. Memory decline is very common in patients with uncontrolled seizures. They just, you hear over and over again. In fact, just today in clinic, half my patients, I just can't remember things anymore. And that is a problem. There is an increased risk of unexplained death, and it's rare, but it is more common in patients that have uncontrolled seizures. So epilepsy surgery, why? And it's interesting. You talk about epilepsy surgery, and some people have never even thought of why would you do surgery for epilepsy, but it really is. It comes down to improving quality of life. You would never do a surgery on somebody if it ultimately wasn't going to improve their current situation. The epilepsy surgery evaluation is essentially once a patient's been diagnosed with epilepsy and not responding to medications, that's when you'd consider doing the surgical evaluation. And you'll hear the term refractory, medically unresponsive types of epilepsy, and this is diagnosed. It's a common diagnosis would be at least 2 medications that were properly chosen at adequate doses, not controlling seizures. That would be this refractory epilepsy, and those are the patients that surgery would be considered. The evaluation is it can get a little complicated, but there are very, very specific testing that is required to make sure you're find the exact area of the brain that's being affected. You don't want to do surgery if you end up taking part of the brain out and the patient still has seizures. That's definitely not what anybody wants. It starts with a detailed history, a physical and neurologic exam, and then to go over this testing, EEG with the video and audio, and then all of these fancy scans, and we'll talk about those. A psychological evaluation is very important to make sure somebody is fit for surgery, not just physically, but psychologically. Again, this is quality of life. Um, so we will talk about phase 1 and phase 2 testing. We start with phase 1, and it's a non-invasive testing, meaning that you're not going to really inject, or you're not going to go into the body necessarily for this type of testing. You start with an EEG, and down here is just a depiction of this. Uh, these top 4 lines are the left temporal lobe, and you're seeing all this different activity. And this is the right temporal lobe, and this is a lot of sharper and more rhythmic-like activity. And this, the EEG, helps localize the general area. No real specific areas, but just in general where seizures may be coming from. And then we always need to look what the patient is doing physically to make sure that makes sense. And we look for these spikes and sharp waves and also seizures. Phase 1 definitely includes imaging, which looks at the structure of the brain. The EEG looks at the function, but we definitely need to make sure there's no tumors and scarring. There's a special type of protocol or procedure that we do with the MRI. And just a regular MRI that your doctor might order for you is not sufficient. We have a very, very specific things that we're looking at, and we have the radiologist do a specific epilepsy procedure with the MRI. It's just a little more detailed. There's functional MRI, PET, SPECT, MEG, and we'll review all of those. This is just a basic MRI picture. This is functional MRI. This is what a PET scan looks like. Ictal SPECT, and MEG. And I'm going to go through each one of those in more detail. So MRI, everybody has reviewed, so we don't need to go into too much depth about that. But this functional MRI may be a new concept. This is a 3D reconstruction of MRI. So this is the structure, what the structure of the brain looks like. And then these colors, these represent different areas of function. So in this particular case, in this, the radiologist or a technician or sometimes a psychologist will give the patient things to either remember or to say, and this is a language function, and this is where expressive speech is located. You can also do different finger tapping techniques to find out where the motor activity or the function is, and sensory function, hearing, vision. So there's different ways that we can look at the function of the brain through an fMRI. PET stands for positron emission tomography, which is it's pretty interesting the way that they do this. They need to put an IV in and inject a nuclear medicine. It's actually a sugar molecule with a radionucleotide, so a very tiny radioactive material that's tagged onto that sugar, and that's taken up by the brain and helps us understand how the brain is metabolizing or using sugar. And if the test is done at rest, we can see a decrease in activity. And I don't expect anybody to really know in particular what we're looking for. And we just compare side to side. So in this left middle part of the temporal lobe, there's not as much activity during rest. If you do this during a seizure, there'll actually be a brighter spot or an increased metabolism. And very similar is this SPECT, single photon emission computerized tomography. Pretty, it's a high-tech radio nucleotide. So they, again, you need an IV and inject this radioactive material, and this shows us blood flow. So areas where there's increased blood flow, and this was actually during a seizure, and this is where the increased activity was. And this, again, this is the left temporal lobe. MEG is a technology that not a lot of centers have. One of our epilepsy level 4 centers has one of these at Overlook Hospital, the Atlantic Health System. But there's only about maybe 20-25 of these machines that are used for this type of evaluation in the nation. And we're very lucky to have one of those, which can help us. It's a non-invasive test, and it detects these tiny magnetic fields. If you think of a magnet or the Earth's magnetic field, this your brain actually emits or generates electrical fields, electricity from the abnormal brain activity, and that electricity in turn creates a magnetic field, and the MEG is a very, very detailed way to analyze that abnormal activity, significantly better than the routine EEG. We're talking on the range of millimeters in accuracy. Also part of this phase 1 is neuropsychological testing. Very important to understand what the patient's baseline IQ is, IQ testing. Also to test their verbal memory, memory of words, nonverbal memory of pictures, processing speed. How quick on your toes are you? How are you able to process a large amount of information? Test language, function, and also mood. Again, very important part of the, and often overlooked or underappreciated part of the epilepsy surgery evaluation. At times, there are tests, minimally invasive tests. This is it's called a WADA test, named, this is somebody's last name, and this can test for language to find out which side is dominant. Are you always hear, are you left hemisphere or left-sided dominant or right-sided dominant? Sometimes, in most people, if they're right-handed, their left side is going to be dominant, but not always in left-handed people. And this is just an example. So a radiologist or a neurosurgeon or an interventional doctor will put a catheter up through your groin and put that catheter all the way up to this carotid artery and inject medication that's going to numb, essentially put half the brain to sleep. And while the brain's asleep, we can test the function of the opposite side. And in that regard, we can tell which side is dominant for language and also a little bit for the memory. Very interesting test. So just to switch gears a little bit, we'll go into a phase 2 testing. So the phase 1, very in-depth, but not a lot of invasive evaluation. So again, just to, I think to illustrate the point, we'd just go through a case, one of our cases, just in great detail about how we would go about doing epilepsy surgery. So again, this is our 20-year-old female with the seizures that were not controlled with medication or refractory epilepsy. So 3 years uncontrolled with medicines. She did have that fever as an infant, which oftentimes can cause that scarring on the brain and lead to seizures later on in life. But essentially normal exam, blood work fine, and the MRI showing that scarring or this mesial temporal sclerosis, which is a common cause of refractory epilepsy. The routine EEG showed these spikes, and then her diagnosis was confirmed as left temporal lobe epilepsy. Treatment initially is anticonvulsants, but she just wasn't responding to those. So in infancy, these are the anti-epileptic drugs from age 1 to 3. She was on those medicines, but then was completely seizure-free and off all medicines until she was 17 years old. and then began having 2 to 3 seizures per month. What she would do physically, she would have an aura. She would get very nauseous and then start to have this lip smacking, or this automatic, we call them automatism, um, over and over, and then lose awareness. So she would not be, after the initial nausea, would start to fumble around with her fingers and also smack her lips, and then lose awareness and say as incomprehensible words, and rarely have a grand mal type seizure. Most of her seizures were that type. Current anticonvulsants listed here, previous medicines, several previous medications that just weren't working, and these two aren't working either because she's still having seizures. Had several video evaluations, and the imaging showing this bright spot in the left temporal lobe and the deep middle part, or the mesial part. The scarring is called sclerosis, mesial temporal sclerosis. I don't expect you to be EEG experts, but I do want to just point out some very basic things. Um, all of these lines represent different areas of the brain, and this area in particular, these numbers and letters here, this is the left temporal area, and here we have a spike that you can see in this left temporal area, and you don't see it anywhere else. This is otherwise normal brain, just this abnormal activity here. And this is actually the onset, or where one of the seizures began. You see this sharp and rhythm-like activity here, and it starts to spread to the rest of the brain. But definitely the onset is this left temporal lobe. But it's very broad and basic, and we know that it's in the temporal lobe, but nowhere specifically, not with the EEG. So very important, had a neuropsychological evaluation, having IQ, low average of IQ, and you can see the scores here. Math was a 7th grade level, but a lot of people are bad at math, so I wouldn't take that with too much weight. And then average language function. So functioning adult, essentially, doing well, other than the seizures. The WADA test, this is internal carotid artery. So the artery is going to the brain. This is on the left side. And she stopped talking, or the medical term is aphasia. So, and then had a decent memory recall, but was definitely unable to talk. The right internal carotid artery, she could speak just fine, and memory was great. So she was definitely left side dominant, which is a concern because she had left temporal lobe seizures, and you definitely don't want to remove an area of the brain if that's where the function is. You don't want to do surgery and then leave somebody without being able to speak. So you get all of this data. This is a busy slide, but you get all of that, we call it non-invasive, or this phase 1 data. And if it all makes sense and it all matches up, then we proceed to the second phase of surgical evaluation. So there's a lot of people in the room. There might be 3, 4, 5 different epileptologists, a couple of neurosurgeons, the neuropsychologist, at times a psychiatrist if needed, nurse practitioners, and social workers. There's a lot of people in the room, and these people are all working behind the scenes. Patients don't often realize in a surgical evaluation they might see their epileptologist several times, meet a neurosurgeon once or twice, but a lot of these people are working behind the scenes, looking at very, very detailed information. So shifting gears again, going into this phase 2, if the patient has, we've felt that they're a good candidate for surgery, we would proceed with this, we call it invasive testing, or actually going into the brain itself and putting these different grids or strips or even depth electrodes. So these are just images of this this is a grid. There's 64 contacts and different sizes of grids, and these some strips. These are just different types, and all of these cables coming out feed into a computer, and we're able to record exactly what's going on underneath each individual electrode. These electrodes can go right into the brain like a shish kebab skewer, and a crude way of thinking of it, but they can go right into the brain tissue itself and record in several different areas. This is an example of implanted brain. You see the brain tissue, you see some blood vessels, and these are each individual contact where we're recording data. Then there's some strips that are being placed underneath different areas of the brain as well. This is just an X-ray showing the the post-surgical changes, and you see all the wires. There's a lot of wires coming out. This is a 3D reconstruction just of the surface, and you can see very detailed staples where all the wires coming out of the scalp. And we have pretty sophisticated software that can do 3D modeling, 3D reconstructions of the brain. Again, patients don't often realize how much detail is going on behind the scenes. But this is a front view. This is looking at the brain from the front, and this is a side view looking at the left side. And there's different strips going in the front area and the temporal lobe, and even back here in the temporal lobe, just to make sure seizures aren't starting in different areas. And this is just a video of the brain that's implanted. So this is just some of the detailed information that we get. You can see there's a lot more squiggly lines on this than there is just on a basic EEG. And we can see this red line where a seizure starts. You can see some spiking activity, which becomes more and more dramatic. And this next page, this is a seizure that just keeps going on, and the electrical signals just keep getting bigger and bigger and bigger until it starts to spread to most of the brain. And then it will abruptly stop, and that brain becomes exhausted, and just you can see the waves just flatten out. So this is just some of the information that we get from the grid and the strips. We can actually model or map out where the seizure is coming from, and this yellow area shows us exactly on this temporal lobe which contact in which area the seizure was began. And this is just another 3D model of the same information. There's some pretty interesting bedside evaluation as well. This I'll explain what all of this is. So we take the brain and we have this 3D reconstruction of all of the electrodes. And we're able, at the bedside, the patient's awake, and we can have them either read a book or count numbers, or count backwards, or simply just talk. And we can, with a separate machine, we can send an electrical signal, in essence, a microscopic shock, if you will, and you can shock each individual electrode and find out what function is underneath that. Because if you have a speech or language function in an area that you're considering doing surgery on, you don't want to do surgery on a patient that's going to leave them either paralyzed or blind or unable to speak or process information. That's not the point of surgery. The point is to improve quality of life. And the red areas are speech. This is where you understand speech, and this is where speech is expressed. There's other areas of speech that were found but not as pronounced as the others. And all the darker or the lighter blue is we've stimulated those areas, but there was no speech or motor function under there. So again, we meet with all of the the epilepsy specialist, the neurosurgeons, the nurse practitioners, case managers, neuropsychologists. We meet again, and if all the data makes sense, then we can proceed with actual brain surgery and take out that focus, that area of the brain where the seizures have started. So this patient did end up having surgery, and this is a CAT scan after the surgery. Again, this is this darker spot is actually the area of brain tissue that was taken out, and you compare that to the right side where the brain tissue is still there. And this is just a front view, and this is again this left side where the temporal lobe has been removed. And the patient has not had a single seizure for 2 years and was having several seizures a month, unable to work, unable to drive, unable to care for her children, and not having a seizure for 2 years is turned her life around. It's pretty amazing. Quality of life definitely improved in this case, and not left with any major memory loss. There is a possibility of loss of some memory with surgery, but if you compare that to having uncontrolled seizures for years and years, the overall data is very promising. Outcomes. Not everybody that has surgery for their seizures is seizure free. In fact, the seizures are successfully stopped, and 60 or 6 to 7 out of 10 patients never have any more seizures the rest of their life. However, there are 3 or 4 people that actually do have the surgery that would continue on having seizures. So the fact that we do all of this amazing testing and the surgical workup and all those fancy pictures that I showed you, the reality is some of those patients do continue to have seizures or may develop those later on in life. And there are several different reasons for that. Some people's brains are just, they start having seizures in different areas for whatever reason. There's also the chance that you got the wrong spot, which is does in fact happen, but with more experience and the more dedicated centers, this is much less likely to happen. And these are temporal lobe surgeries. And we also have extra temporal, so at frontal, in the front part of the brain or the back part of the brain. Once you get out of that temporal lobe, the success isn't quite as high, but still, 1 out of every 2 patients can be possibly off all medications and never have another seizure the rest of their life, which is pretty amazing. This last bullet is pretty interesting and very unfortunate at the same time. This is the average length of a patient having seizures until they have surgery or even a surgical workup, 17 years. So somebody, say a 17-year-old, might be 34 or older before surgery is even considered. And if you could do surgery, say at age 20, for example, this girl, when she was 17, when she started having uncontrolled seizures, 3 years later has surgery and is seizure free the rest of her life. That's a lot of years to be having seizures if that surgery wasn't properly even considered by your neurologist or epilepsy specialist. Not everybody that has a surgical workup can end up having the surgery, but it is very, very important to look. So again, reasons not to have surgery. If the seizures are controlled with medications, then you just wouldn't even consider it. It's just at least with our current data and current technology, medications, if they're controlled with seizures, there's no reason to have neurosurgery. Controlled with medications, there's no reason to have neurosurgery. If you have a seizure that starts in a speech area, You don't want to cause somebody to be unable to speak, and that you definitely wouldn't want to do surgery. And also areas of function where you don't want to render someone paralyzed. That's definitely not the point of having this surgery. Um, so what happens if you do all of these MRIs and PET scans and MEG, the neuropsychological testing? What if, even if sometimes patients have that invasive, they've had the grids on the brain and all of that, and so what if surgery is not an option? And you go over that, all of this, there, or if you have that other type of epilepsy, this generalized epilepsy, then there are a couple of other options as far as surgical options. There's other options as well, but specifically or surgery. There's a device called the vagal nerve stimulator. It's an implanted device. This is a cartoon. So this device is like a pacemaker, and it's placed directly under the skin. And then these wires go to an area in the neck, and this yellow is a nerve, and there's electrodes that go right around this nerve and stimulate it. It's stimulated on and off 24 hours a day, 7 days a week, 365. So, and this is a device that can actually interrogate and program the a nerve stimulator, and you use it as if it were a medication. You can quote unquote dose it. So different doses of the nerve stimulator. It can be very, very successful in certain patients. You can also, there's a magnet that you can carry or wear on your wrist that you can swipe across here if you had an aura or if you had some type of seizure. You can, you or a family member could swipe across this and it activates it and gives it a little extra dose and some patients will be able to stop a seizure from progressing. It's not a cure for epilepsy. There's also a device called NeuroPace, which is in the process of being FDA approved. It's not quite approved yet, but has passed a committee. And it's a device that's, there's a part of the skull that's drilled out, and this goes right in a bed right into the skull itself. And then there are wires that go deep inside the brain. And for example, this wire is going into the temporal lobe. And here's the device here, and there's a capability of 2 of these electrodes to be put in different areas of the brain, and have found some success of decreasing the seizures. This not only stimulates, but it actually can record brain activity at the same time, and quite an interesting test. So there are options other than removing brain tissue. There are a couple of other options for electrical stimulation. So I hope that it hasn't been too complicated. I try not to make too many specific doctor terms, and just wanted to go over again basic evaluation of the diagnosis and what is epilepsy, review different seizure types, this focal or generalized seizure types, and then we reviewed this phase 1 testing, all the non-invasive MRIs and CAT scans and psychological testing, etc. And then we reviewed phase 2, which is the actual implanted electrodes onto the brain. And then we talked about epilepsy surgery and implanted devices. So thank you for your attention. This is our website, and there's a lot of good information that you can get, epilepsygroup.com. You can click on each one of these different sections and learn about our center, services that we provide, and also just in general um, answers to simple questions. We have several level 4, which is the highest level of epilepsy care that's available nationwide and in fact worldwide. And please send any of your questions from tonight to epilepsynj or epilepsyny at epilepsygroup.com. And again, our goal as physicians is no seizures uh, and no side effects of medications. And when medications aren't able to control seizures, we have the technology, the capabilities, knowledge, and experience to do the epilepsy surgical workup and epilepsy surgery. Again, thank you for your attention.